All right. Welcome, everyone. We will still be accepting admissions. Meanwhile, I will just remember on the SSNC multi-country seminars. So today it's March 31st. So we are going to discuss monitoring and thermal care. We have already discussed the care at birth, respiratory support, and KMC. These three seminars, they can be reviewed on our YouTube channel, which is at ACSIR MCAWHO, or you can also scan now this QR code and you can reach them on YouTube. So the seminars will be there for the whole duration of the research, and they are accessible freely to all the research teams and the mentors and the champions. For now, the presence of the mentors for phase 2 is required for the seminars. Otherwise, for those who could not come to the seminars, what we will request is that you watch the seminars. So today we are going to start talking about thermal care. Okay, can you see my screen?
Yes, yeah, Flavie.
So today we'll be talking about thermal care and monitoring. This seminar is being recorded, so we can put them and diffuse on YouTube after that. I'll just request that everyone keeps their microphones on mute. And if you have any questions through the seminar, please don't hesitate to write in the chat. We're going to be monitoring it. We also have some interactive parts, some interactive slides that we will be requesting you to kindly also follow in the chat. And after, we are still going to have time for discussion, and we will also have some time for seeing the job aid on this subject. Okay, so the objectives of this session are discussing thermoregulation and monitoring of neonates, the mechanism of hypothermia in a neonate, how to prevent hypothermia, how to treat hypothermia, thermoregulation devices, and monitoring of the neonate. Starting with the temperature. So what's normal? The normal temperature in a neonate is from 36.5 to 37.5 degrees Celsius, which equals to 97.7 or 99.5 Fahrenheit, and taken in the axillary region. So it can be also taken in other methods, but for us, for this research project, we are recommending taking in the axilla and with a digital thermometer. So why are babies prone to hypothermia? Small babies lose heat because they have a large surface area in relation to weight. They also have large heads. They have thin skin that is permeable to heat, and we can see more of these in smaller babies and preterm babies that are our population here. They have little or no subcutaneous fat. They are unable to curl up to reduce heat loss. They cannot move around to generate heat. Many times they won't be able to move at all, especially if they're sick. They cannot shiver. So neonates in general do not shiver. They don't have what we call shivering thermogenesis. And on the top of it, they are born wet and naked, which prone them to become cold more fast. So the WHO classification of hypothermia is normal temperature from 36.5 to 37.5, as we said. Mild hypothermia will be from 36 to 36.4, moderate hypothermia from 32 to 35.9, and severe hypothermia less than 32 degrees Celsius. So why this is important? This is important because there is a mortality impact on temperature, on hypothermia. And we know that for every 1 degree of decrease in admission temperature, the risk of sepsis increased by 11%, and the risk of dying increased by 28%. Therefore, temperature is extremely important in neonatology. It's a factor that is easily modifiable, and it's usually an outcome in neonatology in general. For this research, temperature on admission is one secondary outcome. So what happens from fetus to neonate? So in utero, we have a hot environment. There is almost no losses. The losses are very, very small, and the losses are basically because of excess of heat. And there is a lot of substrate. The fetus is receiving a lot of all of he needs, basically through the umbilical cord. And then after birth, everything stops. Everything, and then the environment is cold, the losses start, and there are different forms and sources of losses. And there is also no more substrate because we cut the umbilical cord. So how the fetus produce and dissipates heat in utero, that's what we call fetal thermogenesis, which results from vital biochemical reactions. And in the third trimester, the fetus produces twice the heat production of an adult. So it's a lot of heat that is being produced by fetus. And this is because there is a lot of, the fetus is growing really, really fast. And there is a lot of anabolism. And this produces energy. This produces heat, basically, as a form of dissipation of energy. So the fetus needs to handle all of this energy, all of this excess temperature. So there is some loss of temperature through the placenta, and some of these losses are external, so from the liquid, and go from contact, basically, through the liquid and through the womb to the skin. Regardless, the fetal temperature is always 0.5 degrees Celsius higher than the maternal temperature. So basically, a baby at birth will always have a little, slightly higher temperature on the immediate moment that the baby is born than the mom, which also means that a mother who is having fever at birth, the baby will come out very hot also, and the baby will also have fever just at the moment the baby is being born. So after birth, we have 4 main mechanisms of fetal loss that all of you know. So we have convection. Basically, a baby is exposed to air, and just the air temperature that is different than the skin temperature. Even if you have, of course, wind, if you have air current, the convection increases. But just by having contact with cold air, with cooler air, there is a heat loss. Also evaporation, and evaporation is extremely important in preterms, especially in extreme preterms. They lose a lot of water through the skin, but also babies that are full term, that are born very wet, they lose that water that's also on the skin, will evaporate. And every time the water evaporates, we lose basically heat. Conduction, so basically the contact surface where the baby will be put on. The baby might lose or get temperature from it, depending on the temperature it is. So that's why the best place to put the baby is on moms, because it's already warm. But if you put the baby on a table straight away, or on an environment that is cold, the baby will lose temperature to this place, even if it's a little bit warm, but cooler than the baby. And radiation. So radiation is the loss of temperature to all the structures in the room. So we have, for example, walls, and these walls, they are cooler than the air itself, than the baby itself, and they might also lose temperature to that. So everything that's happening around the baby will be interacting with the environment, and everything that's cooler will tend to take temperature from them. Also, what doesn't help is that the body, the small body size of the baby makes it in the way that there is a high surface area to the volume ratio. So if you look at an adult of 70 kilos, they have 1.7 square meters, which is 0.025 meters per squares per kilo of body surface. When you look at a neonate of 3 kilo, The body surface is 0.25 meters square, which is like, okay, it's smaller than the adult, but when you look per kilo, is 0.08, which is much higher. It's almost 4 times higher than an adult. So basically more body surface area that is exposed means more surface that will be exposed to cold and then more heat loss. And if you're on the top of it, you have cold air, cold walls, there is this heat loss by radiation and convection that is happening. We know that there is a drop of 2 to 3 degrees Celsius if there is no precautions are taken, just by radiation and convection. So there is also evaporation that's happening. So evaporation will happen in any baby. Of course, we have more evaporation in preterms, but also full-term babies that are born and that are very wet. There is a quick drop in the body temperature. And we know that evaporation, it causes energy loss. So for each milliliter of water that is evaporated from the skin, equals to 560 calories that are lost. So basically, a baby that is losing a lot of water through evaporation needs more energy. They will consume more energy. This means they will consume more glucose. So what's the baby's response to cold? There is a limitation of heat loss. Initially, you're going to have basically a vasoconstriction. All of us have vasoconstriction, cool extremities. But then the thermogenesis will differ to the thermogenesis from adults because the neonates, they don't shiver. And they don't have adipose tissue that's readily available like us. So they will basically take the energy from brown fat tissue. It's a brown adipose tissue that we find in these areas that you see that are a little marked brown. So it's not a lot of areas that we have it. And it is brown fat is also limited. So either way, through thermogenesis, even if you're using brown fat, there is an increased consumption of glucose and oxygen. Just of course, glucose and oxygen equals to energy. And this is what you need to produce the temperature. Temperature is energy. So of course, any baby that is exposed to cold, even before they become hypothermic, they will need more glucose and more oxygen. So the baby with respiratory distress, we need even more oxygen if they're cold. And then, therefore, the baby that is also hypoglycemic may get even worse because they will be consuming more sugar. And of course, all of you know that we get in this vicious cycle. Well, cesarean section, even cooler. So cesarean section, we know that babies that go through it, that are born from cesarean section, they have a lower baseline temperature at birth. That is minus 0.3 degrees, median lower temperature in term newborns, which will say, okay, it doesn't look like much, but it does make a difference. And if you look at preterms, it's each decimal of degree of temperature is very important. We also know that these babies have lower stress hormone levels when they don't have labor, so programmed cesarean section, which doesn't help them on reacting and producing heat, basically. So there are many effects of hypothermia, but making it very simple, it worsens RDS. Baby can basically just flip into PPHN, failing to transition, basically. You can cause hypoglycemia itself, can worsen hypoglycemia. You can make refractory hypoglycemia, and hypoglycemia can do the same. On the other hand, a baby that is hypoglycemic is more difficult to heat, to warm, and it can also have refractory hypothermia. If it gets worse, especially when you have a severe hypothermia, you can have an impairment of the coagulation system, and you can have a dysregulation of it, causing disseminated intravascular coagulation, bleeding, and shock. And it can cause up to death, basically, on that sense. So hypothermia is a very underestimated and can be very severe. And even when it's not severe hypothermia, will have important effects on a neonate. So what do we want? We want to keep a neonate on what we call the thermoneutral zone. The thermoneutral zone is the range of environment temperature at which the infant maintains normal body temperature with minimal energy expenditure and oxygen consumption. If you look at this figure, I'll go through it with you. So on the top, we have body temperature starting at 37 degrees, that's here, and it keeps going up. And on here, we have heat production or oxygen consumption, because to produce heat, you need oxygen. And on the bottom, you have environmental temperature, right? So this line here is 37 degrees. And then we have our baby that is here, this area here, 37. Part of it is what we call in the thermoregulatory range. So it's in the range that we want our babies to be. And inside the thermoregulatory range, we have what we call range of thermoneutrality. At this range, you see that the heat production and energy consumption is minimal. So we have a baby that is being warm, or it's warm enough that he's not using any energy, extra energy, basically, to thermoregulate. So that's the simple thing. So if it's let's say the preterm baby that we put on KMC, and it has the extremities warm, the baby's warm, the temperature is 37, this baby is in the range of thermoneutrality. It doesn't have to be 37. Each range of thermoneutrality for each baby is different, but it's always in the normal temperature range. If we keep heating this baby, let's say we take the baby, we put in a radiant warmer, and we say, okay, let's change the diaper in the radiant warmer. We put heat on the baby. We keep heating the baby. The baby is here in the range of thermoneutrality. We keep heating the baby. The temperature is still normal. And then we keep heating the baby. We reach a point where the temperature is still normal. And then the baby will start increasing his body temperature, because he will reach a point where he cannot thermoregulate. He will not lose temperature anymore. He cannot thermoregulate anymore. And then he'll start heating until the point that we can have a heat stroke, and then we can die from heat. So we don't want that. On the other end, which is mostly what we are talking about, is that you can just say, okay, let's put a baby, that's that baby that you have, and it's on a baby bed, or even sometimes in an incubator or in a radiant warmer, and you touch the baby's food, and the baby's food is a little bit cold, but you look at the temperature, and the temperature is normal. And then the nurse will say, wow, the temperature is normal, it's 36.7. So the baby's foot is still cold, but temperatures are normal, so I'm fine. But actually, this baby is already here, already entering that area where you have still a temperature normal. We are still in the thermoregulatory range, but the baby is getting cold. The baby is already increasing the metabolism, increasing the oxygen consumption to maintain temperature. If this baby keeps getting cold, many of these babies, they will keep monitored, in a good hospital, and then they will just keep in this area. These are the babies that maybe have some low sugars, or maybe will just not gain weight so well. And for term babies, they will sometimes tolerate really well, but preterms usually there's these ones that then have borderline sugars and they don't tolerate so well. They don't gain enough weight, and you say, oh, this baby's not gaining weight, you have to increase feeds, but sometimes you just fix this, and you fix the sugar issue, and you fix the feeding, and so on. If you keep going down on that, okay, this baby is still getting cold. Nobody looked at the baby, and the baby, well, needed a little bit more of heat. We didn't put the baby on KMC. The baby is still on the bed, and the baby is still getting cold. The baby will reach a point here where he'll break the thermoregulatory range. This baby will start becoming really hypothermic. And you have the maximum, the baby will reach the maximum of energy that he can spend, basically. The maximum of metabolism that he can manage, basically. And his temperature will start going down. Then we have hypothermia. And if nothing is done here, well, we have the opposite. The baby will basically not be able to cope anymore. All energy is lost. And then we have basically a metabolic failure. And then we can reach death, basically, from cold. So what we want from our babies, again, is to be here in the range of thermoneutrality, this range where everything is warm, and the temperature is normal, the baby is warm, the feet are warm, and the baby is basically not spending energy, extra energy to regulate his temperature. So how to do that? The best way to do that is to prevent hypothermia, right? We don't want to baby. If we keep running after it, it's always worse because we already had some loss. We already started losing. So the best way to deal with that is to prevent hypothermia. So to prevent hypothermia, we have to start from birth, basically from planning birth. And the WHO has the warm chain that I'm sure most of you have already heard about. And that's the 10 simple steps that we can do to prevent hypothermia at birth. Starting from warming the room. So warming the room from 25 to 28 degrees. We eliminate drafts and air currents. And then we prepare for immediate drying. So this means we have to have on the side the towels that are clean and that are dry, if possible, that are warm. If it's not possible, at least clean and dry towels. We need to have them on the side. Some places they will not have them, and we can just ask the parents. The parents will bring their own sheets, basically. And then, but just they need to be ready there. And when you have a radiant warmer, you can put them on the radiant warmer while the lady is delivering, and they will get warm, and then you can use them to dry the baby. Then skin to skin. The baby is born, we dry the baby and put the linen that is wet out, cover the baby with a new dry linen, and put the baby on skin to skin care on mom's chest, and follow with KMC. So basically the idea is that at the moment we put the baby on mom, we don't take the baby off unless it's extremely necessary. So the baby will be dry there, the cord clamping will happen, and once everything happens, everything is dry, we start the continuous skin to skin care, which is basically continuous KMC. Early breastfeeding. So of course, again, to thermoregulate, we need energy. So we need the main source of energy is going to be the colostrum at birth. So early breastfeeding for everyone. We are going to have a seminar on breastfeeding next week. Next week, no, in 2 weeks. But we are going to talk a lot about it. But basically, any baby can receive colostrum at birth, even the extreme preterms can receive small amounts of colostrum on the mouth or through an NG tube if we cannot put through the mouth. So we start within 1 hour of birth. Within 1 hour doesn't mean at 1 hour, and this happens a lot. So this is something that we need to improve in the facilities. Within 1 hour means immediately, and we have maximum 1 hour. Provides energy for heat production. Delay bathing and waiting. So we delay bathing for more than 24 hours, and especially for preterms, even more. And this will avoid necessary exposure. Again, remembering that evaporation causes a lot of heat loss. So on the top of it, the baby's naked. So babies are prone to all the other ways of heating loss. Appropriate clothing. So baby well wrapped, ideally well wrapped on KMC, well covered on KMC with a hat and socks if needed. The head is really, really important to be covered. The head has a very large body surface. It represents a very large body surface area. So there is a lot of heat loss through the head. So covering the head, mother and baby together, this makes a big difference. So we do recommend rooming 24 hours a day, promotes warm bonding. We do KMC 24 hours a day, and this is extremely important. Warm transportation. So the babies that are born in peripheral facilities, they need to be transported. This is one priority, that the baby is warm before the transport. So the baby leaves already warm. And the baby is kept warm during transport. We can use warm wraps, we can use KMC, and we can use transport incubator. Warm resuscitation. So again, pre-warm radiant warmer, we can put the towels, and we pre-warm the towels on the radiant warmers. We do recommend radiant warmers for all delivery rooms, including for the delivery rooms of peripheral facilities. And all resuscitation should be done, all intervention that's supposed to be done to a baby after birth to be done, that cannot be done on skin-to-skin care, to be done on a warm environment. And training and awareness, that's part of what we are doing here, but it's more what you are going to be doing when you are going to the facilities and doing the trainings for the champions, and also doing the immersive training for the champions, and also the training for the staff. This is just a support that, of course, can be used by all mentors, and this is extremely important. And this is interesting. We did a survey that we published a few years ago in my hospital, a survey that we did in low and middle income countries. And in this survey, we asked about the importance and quality of the practice of WHO warm chain. And we see that most of the professionals, so the red columns, are the ones that acknowledge importance, and the green columns are the ones that acknowledge the level of practice. So what you can see is that most of the cases, more than 90%, are only delayed bathing, which is very concerning. But mostly around 90% acknowledge the positive impact of the warm chain. But when you look at the practices, there is a divergence, basically. Skin-to-skin care, that 98% acknowledge that it's important, only 73% are doing in their facilities. Same thing for awareness and training. So we do need training. And this is a big part of this research project. Also, delayed bathing looks like this is not taken as important as it is. And we go through all the items. There is always a discrepancy, basically, on what people do and what people think it's important. So there is a lot of work, basically, also on advocacy and on changing policies in hospital and promoting practices, not only training. And this is a lot of the work of the mentors. So that's a lot to do. So patients at higher risk of hypothermia, who are these babies that we are talking about? So preterms or small babies, less than 2.5 kilos, hypoglycemic babies, babies that are on phototherapy. I think this is, I'll just make a pause here, because phototherapy, everybody associates to hypothermia. The new lights for phototherapy, well, we will see all kinds of lights during the in the facilities, but the new lights, the LED lights, they don't heat, so they are unlikely to produce energy and to heat much these babies. But we do see babies that are placed only on a cot, baby cot, without heating. They have to be completely exposed, and then they have the lights on them. So then they have a higher risk of hypothermia, because then they will have this loss to the bed that is cold, that's not being warm. They will have the loss to the walls of the bed. So this is an incubator, but if it's a baby cot, they will still have walls. So they will lose to the walls, they will lose to the air, they will lose to the walls of the room. So you have all kinds of heat loss apart from evaporation that will be caused in a baby that is on phototherapy and it's not being warmed. So it's also a risk. So a baby that's on phototherapy is completely naked. So we just have to remember that. Any temperature instability for any reason, so sepsis, respiratory distress, all these babies, they and all sick babies in general, they will be prone to temperature instability. These babies, they will have higher risk of hypothermia. Parenteral fluids, babies that are not fed, especially, and are only on parenteral fluids, especially if in cold environments, while we're putting cold fluids on a baby, and especially if you're flushing. When we give several boluses in resuscitation, there is a higher risk of cooling the baby. Observations requiring exposure of upper and lower body. So yes, so I'll have a baby that is pretty warm in the incubator. We open the incubator. Sometimes we don't have double-walled incubators. Of course, there is a lot of cold air that goes inside straight away. Same if we have a baby on KMC. We take the baby, we open the wrap. The baby is completely exposed to air. There is just the contact with mouth, but there is the whole air current that is going, and then there is a risk of hypothermia. And surgery, prolonged procedures, sedated babies, these are more for other contexts, but these babies are also at higher risk of hypothermia. So, going to the recording, of course, how do we, it's very important to record temperature and to monitor to be able to detect basically hypothermia. So we recommend axillary temperature. It's around 3 minutes if you're using mercury thermometer. We do recommend this thermometer. I have a blank right now. For neonate, with digital thermometer. There are different ways, there are two main different ways of measuring. So if you have a full-term baby, you can put the thermometer parallel to the baby like this. We just have to remember the nurses when you are looking at them and we are seeing them measuring it. When you have a very, very small baby, sometimes the probe of the thermometer will cross the baby and then we're measuring the air temperature. So we just have to remember that it has to be very snug, fit snugly the arm, have to hold the arm so you don't have contact to air. Every 15 minutes for the first hour, every 30 minutes for the second hour, and then 2 hourly and 4 hours per need after birth, basically. So it does need to be monitored at birth. So this is also some work that we'll need to be doing with the staff in the delivery room. Even if a baby is on KMC, of course, it's the baby have lower risk, but they will still have to measure the temperature of those babies in the delivery room. Measure the temperature before you have to have an immediate temperature on arrival in SNCU and keep monitoring temperature in SNCU. So we can also evaluate temperature by hand touch. And actually in the community, it's a very good method if you don't have a thermometer. But basically cold feet are a sign of cold stress. Basic cold feet is a sign that the baby is outside of the thermoregulatory neutral range zone. So that means that the baby is already starting to feel cold and increasing the metabolism to produce heat. So cold stress triggers vasoconstriction, leads to metabolic heat production, and with major substrate and oxygen consumption, and also may limit all other organ functions, basically. So it's interesting. We did also do in this survey that we did with health workers, we had 27 of participants that reported that checking the foot or hand temperature by hand touching the skin of the feet or hand was useless or extremely useless. So basically 27% thinks that evaluating by hand and touch, that looking for signs of cold stress is useless or extremely useless. And actually 16% of them declared that it's not useful or useless. So they were, actually they were neutral. They were not nor useful nor useless. So we have a good amount actually of healthcare workers, more than 40%, that still don't do detection of cold stress, still don't look at it, and still don't understand cold stress. So going to hypothermia per se, we have clinical indicators. We start with cold feet, and then it gets worse, right? The vasoconstriction, cold, pale, mottled screen, and then we can have a baby that's lethargic, has feeding intolerance, vomiting, increasing gastric aspirates, increasing oxygen requirement because consuming more energy. Baby with respiratory distress will worsen respiratory distress. Baby that needs oxygen will need more oxygen. And babies can also have apnea, bradycardia. Bradycardia is really common, or just basically lowering down the baseline of the heart rate. Hypotonia and hypoglycemia, as we all know. So there are modes of temperature control. The best way to do is to prevent. When you cannot prevent, we will treat. But with the different modes of temperature control, we can do both, basically. So the first mode of temperature control is KMC. So basically, WHO published in since 2023 a global position paper on implementation strategy for KMC. And we recommend that every preterm all over weight, meaning less than 2.5 kilos infant, should receive continuous and prolonged KMC initiated as soon as possible after birth. This recommendation applies to infants born at home who do not need medical care in health facility, and those who are born in a healthcare facility also, except if the infant is unstable, meaning the baby cannot breathe spontaneously after resuscitation, the baby is in shock, or the baby needs mechanical ventilation. And even for babies with mechanical ventilation, it's not saying that we're not supposed to do. We are doing more and more for babies with mechanical ventilation. But for these 3 babies, we can use alternative methods, basically, of heating. Regardless, KMC is a de facto conductive warmer, right? Because we have the baby that is touching the surface that is warm. So mom will be around 37 degrees. So the baby is basically on the warm environment. And we cover the baby to avoid all the odor losses, basically. So we can also have servo-controlled skin or baby mode. So basically, infants on an open care radiant warmer and preference mode for patients that are nursed in an incubator. So here we have a baby on a radiant warmer, and this baby is on a baby mode. So we basically have the baby's temperature that is measured by a probe, and we chose that the baby temperature in the skin should be, this is 36.5. And we have the probe that is attached to the skin of the baby. And the temperature of the baby, as you can see in the skin, is 36.2. So the radiant warmer is warming 100% because the radiant warmer has an algorithm that will understand that this baby needs to reach 36.5 in the skin. And it will warm the baby until the baby reaches the temperature. And if the baby goes beyond the temperature, the radiant warmer will stop completely or just heat a little bit. The same way, if the baby gets very close very fast, the radiant warmer will start reducing. So this is a very, very good method and very safe if we have the probe that is attached properly to the baby. So the radiant warmer or the incubator on servo control will control the infant's temperature in a specific range by adjusting the radiant heater output to achieve the desired preset skin probe temperature. So it's very useful, especially when we are rewarming a baby that is very or severe hypothermic. We can set the probe temperature to a higher temperature than the baby, and the radiant warmer will warm the baby. But you can also avoid the radiant warmer to warm the baby too fast. It can happen overheating again, but usually it will happen. The probe is detached fully or partially, not the probe itself. Sometimes you just have the sticker that will go up a little bit, especially in small preterms, especially when they are in an incubator that is humidified. It will go up a little bit, and there will be air that will going through below the sticker, and it will basically make the machine understand that the baby's skin temperature is lower. So the machine will heat, and of course it's not the real skin temperature, and the baby will get hot. So if overheating happens, so basically just need to make sure that everything is well attached, decrease the set temperature, and the control in the baby. What's the WHO recommendation for unstable newborns weighing 2 kilos or less at birth, or stable newborns weighing less than 2 kilos who cannot be given kangaroo care? They should be cared in a thermal neutral environment, either under radiant warmer, either an incubator. So this is recommendations from WHO. Again, this is for babies that cannot be on KMC. So radiant warmers and incubators can also be on manual mode, which many people like, but this is a little bit more dangerous. So you can see these 2 radiant warmers here, they are both on manual mode. This one here is on manual mode, and we do have the probe, so at least you can see the baby's temperature on the skin. And the person decided that the baby shouldn't have heat for some reason. But the thing is that when you decide that the baby shouldn't have some heat for some reason, at least you can see on the probe what's the temperature of the baby, right? Here in this case, the baby doesn't even have the probe. So you just have the heater power that you can go on percentage. And what can happen here is that the baby will get too cold or too hot, depending on what's given to the baby. And if you're not measuring very, very often, it can be dangerous. So usually the manual mode is used for short-term pre-warming of the bed for when you are expecting an admission or when you're expecting a delivery. We just put the incubator on a maximum, put it really, really warm so we can come with the baby on a warm environment. Or it can be used during skin to skin when the skin temperature probe needs to be removed for a procedure. So we just take the baby, we put a little bit, and then we put the baby back to mom. It allows the infant to be assessed and stabilized without risk of hypothermia. You have to pay careful attention to prevent hyperthermia and hypothermia, as the manual mode does not have feedback system again. And if the bed has a non-functioning skin temperature probe, which can happen, especially in low resource settings, we arrive, we have a new radiant warmer, everything is working, and then the probe breaks, we cannot replace it, and then we'll not have the probe, but the radiant warmer still work. So when the bed has a non-functioning skin probe, continued skin temperature monitor should be implemented via bedside monitor. We should keep monitoring. If we don't have a bedside monitor, of course, we'll just keep monitoring with a thermometer, but this needs to be monitored. And we have air mode for the incubator. So the air mode in the incubator is usually useful to preheat the incubator. And this preheating the incubator is extremely important, especially if you want to rewarm a baby. So when you want to rewarm a baby, the incubators take about 30 minutes to heat to about 33 degrees Celsius. So if you receive a baby that is very cold and they want to put the baby on the incubator to be warm, it's possible, but the incubator needs to be already closed and warm before you put the baby. Because if you put the baby in the incubator naked, and the incubator is, the air is not warm yet, it's basically the same or even worse than keeping the baby outside the incubator. So if you don't have a warmed incubator, so this is something important for the sites, most of the times, they will not have an incubator that is preheated. To heat a baby that's on severe hypothermia, the incubator needs to be preheated. Otherwise, radiant warmer would be the solution. So we also published this table in my group on the main devices comparison. So it's basically a paper on how what to do when KMC is not feasible. We made a comparison between radiant warmers, incubators, conductive warmers, which mattresses, and we also have the PCM. The PCM is basically more for transport. It's a liquid that we rub it or we break it. Basically, can be a solid that we break or a liquid that we rub and becomes solid, and it generates temperature, and it's used for transport. And we calculated the accessibility, the risk of overheating, the insensible water loss, the humidity control, the maintenance and repair needed, cleaning, training needs, purchase price, and consumable, and others. And you can see there is a big difference between incubator and radiant warmers, which are the main ones that we are going to find in most settings. You see the energy. Radiant warmer we use sometimes a little bit more than incubator, but it's very accessible. We can see the baby very well. There is a high risk of overheating, again, if you're not using properly the baby mode. Incubator, there is a medium risk. In radiant warmers, there is a high risk of insensible water loss. So that's why for babies that are less than 30 weeks or less than 1.5 kilos, at least each site will have a different protocol, but small babies in general, especially less than 30, 32 weeks or less than 1.5 kilos, it's not the ideal method because you lose a lot of water through the skin. Whereas in the incubator, put humidification and it's very low loss. In the radiant warmer, there is no humidity control, which you have in the incubator. Radiant warmer is medium maintenance and repair. Most of sites are going to manage repairing when the radiant warmer has a mild or moderate issue. Incubators are much more tricky. Incubators are much more complicated to repair and much more complicated to clean. So this is something that needs a lot of attention. We saw this in phase 1, and this is something that enters in the IPC domain, but it's something that's good when you are visiting the sites to also have a look in the incubators, how they are cleaning them. You can open and dismantle them to see how clean they are really, because usually they are not very clean, and it's a high risk for infection, especially in preterms, which are the babies that need the most. We don't need a lot of training for radiant warmer, but for incubator, we need a lot, especially again for operation and maintenance. And the baby mode can be very confusing for many people. Purchase and price. So, well, radiant warmers are expensive, but incubators are even more expensive. And radiant warmers only has skin probe as consumable. Well, there are some now that have other things, that other devices. We have many radiant warmers that have a new puff on it. So they will also have the new puff circuit, the masks and everything that come with it. But basically concerning thermoregulation is not much. Whereas the incubator needs a lot. But again, it's an expensive device, the incubator, to run and to maintain, but it's ideal for very low birth weight babies. But many parts need assembling for cleaning between patients and maintenance. So this is just to remember the difference basically between these devices. The mattresses is different. The mattresses, it's very rare that we see them in the sides. And it's more used for bigger babies. And again, the PCM, which is these materials that heat, they are more used for transport. They can be very useful. They are not very expensive, but they will not be very available in many sites. They are just here also to share. But the main ones that we'll be working on are the radiant warmers and the incubator.
Have you 10 minutes?
So again, going back to hypothermia, what are the ways to prevent hypothermia? We already talked about the devices, the main strategies, but when we are going to do what? So we're going to go for some scenarios very quickly. When you, as a mentor, investigate the delivery room to identify several reasons why the delivery room may be too cold for babies and their mothers. So you have looked at the data, you had the audit and feedback meetings, and you realize that these babies are arriving cold in the NICU. And this happens, this is a real situation. These babies arrived cold in the NICU. So why they are arriving cold in the NICU? So what are some possible reasons, and what actions will you take? So I'll give you some seconds. So if you can, if some of you would like to write on the chat, so the chat's being monitored, and we can have a look at your interactions. I'm sure you're going to have a very nice suggestions. This happened a lot in one of the sites in phase 1, and it was we found some solutions. It didn't end all of it, but there are some steps that can be done. We have one hand, so we can listen to Arif. Please, Arif, go ahead.
Yes, hello. Can you hear
Hi.
me?
Yes. Yes.
Hi. Hi, very good afternoon. Regarding the hypothermia in delivery room, I want to say something, and actually I have so many questions regarding hypothermia of the baby. Should I ask question first or should I respond first?
Yeah, I think maybe we could just keep the questions for the end of the discussion, and now we'll just discuss the scenario if you're okay with that, and would like just to for the interest of time to focus on the scenarios, and then we can go for the questions in the end.
Okay. In our country scenario, most of the delivery room and OT theater, there is actually no radiant warmer. This is the I feel first cause of hypothermia. Other reason is in OT there is so cold, not maintaining the temperature between 25 to 28, and also when they receive the babies from the obstetrician, it was not pre-warm cloth. And again they only use only one cloth, and most of the center they actually don't use two clothes. One is for the dry wrap and one for the covering the babies. So these are the factors which can cause hypothermia. Thank you.
Yeah, thank you, Arif. Just to confirm, are you from Pakistan?
Yes, confirmed. Dr. Alpana has said
no, sorry, he is from Bangladesh. Arif,
Bangladesh.
can you hear me? Yeah.
Flavia, Dr. Alpana has said delay drying and wrapping in appropriate site for management. Johannes, inappropriate building standard, ceramic. Okay, I think ceramic wall. Then someone else has written, Sarah has written draft. Sorry, I'm looking at both things. 1 second, I'm just admitting people.
Yes, I will admit here.
Yeah, draft, open windows, fan, and air conditioners can treat by closing windows and switch off fans, etc. Thank you so much for your responses.
Yes,
everyone.
thank you for the responses. Exactly. So these are everything that you said, all of you. We enter in the warm chain, right? All of these are modifiable factors that are a part, basically, of the warm chain. And this is basically a very good example that you just shared with us of basic things that are part of the warm chain that are there since the 80s, early 80s, actually late 70s, recommended by WHO, and it's too hard to implement. So as a mentor, when you are there, so what can be done to change that? We have a hand, so maybe we can just go through that. Sikandar Hayat, and then we have Arif again. Yes. I just can ask. Yes. Yes. Could you just let us know if you're a mentor or SSNC lead and the country, please? We are still getting to know all of you.
Okay, I'm Arif from Bangladesh. Hello.
Yes, Arif is speaking. Okay, Arif, go ahead. Yes, Arif, you're a mentor from Bangladesh or SSNC lead?
Arif is mentor. Mentor, sorry.
Mentor.
Not SSNC.
Thank you.
Yes.
Good.
Yeah, thank you.
Go ahead, Arif. So you already pointed really well what are the main challenges. So what do you think could be done basically to improve, to implement the warm chain?
First thing, I feel that we should increase the awareness among the healthcare provider and those works in the delivery room. This is the first thing from my side. And after that, we should increase the infrastructure. Many of the centers don't have the infrastructure like warmer and also air condition. And also we can educate the mother as well for the skin to skin care and also KMC. So this all together, if we just implement, then we can do better for our babies. Thank you.
Thank you. Excellent. Agreed. So this is all part of the work that you're going to be doing as a mentor. For the infrastructure, we are already standardizing the radiant warmers in the delivery rooms. So we are going to have delivery warmers, radiant warmers in all delivery rooms for the core facilities for phase 2 when we start the trial. So this is going to be there. How is it going to be used? We don't know. It's going to be part of the job of the mentor and the champions locally to ensure that it's going to be used. And as you said, ensure that we don't have air currents and that we have all the warm chain that's followed. Yes, we have I'm conscious. Yeah, we have maybe just one more, and then we have a few other more interactions, and then we will have to stop again. So, Dr. Adila, please go ahead.
Don't think we have much time. Dr. Sikandar?
Yes, can you hear me?
Yes.
Yes.
Thank you very much for a very nice, discussion, and especially this scenario. I think the most important limiting factor is the awareness problem. I think as a mentor and as a stakeholder, we should first gather the stakeholders and let them know what is appropriate steps to maintain the warm chain for a delivery room. Because currently you can see that the most cold part of the area for newborn and mother is the delivery area. So I think the first thing is the education and awareness. And then is the laid down infrastructure and equipment. Then we can maintain the warm chain for the newborn. Thank you.
Thank you. Thank you. Yes. So prevention of hypothermia during resuscitation. Again, we go through the warm chain. We already went through it. We'll just go again through the prevention of hypothermia, specifically for the preterm babies. One of the WHO recommendations for less than 32 weeks is during stabilization and transfer of preterm newborns to specialized neonatal care wards, wrapping in plastic bags, all wraps, may be considered as an alternative to prevent hypothermia. So in cold environments, especially, or when you are transferring a baby, or when you have a baby that it's when you have the possibility to use a plastic wrap, the baby can be on a plastic wrap. This baby could not have KMC, but even on the mom, we can put a plastic wrap on the top of the mom and then cover with a blanket. And this will avoid losses by evaporation. So this is also one more thing, one more WHO recommendation that I didn't went through it before, just going through it now. But of course, everything that you said, going through education and of the process of change, it's definitely we are in accordance and we are agreeing with that. So how do we prevent now through transport? So for transport, it's very important to let the temperature of the baby stabilize before transport. So more than 36.5 and warm feet, and document the temperature and take appropriate action. So usually during transport, when it's a medicalized transport, so if it's in the hospital, usually it's really fast. So we just have to monitor the baby on the monitor. But if you have a baby that is on an ambulance, the baby needs more frequent monitoring. So we just ask, there's someone speaking. You could put on mute. Thank you. We do recommend transport on skin to skin, or use a transport incubator if we don't have skin to skin feasible, or if it's if you have it as an option.
Let me just see who's talking.
Yes, thank you. Cover adequately to avoid undressing of the baby. So we have a second scenario. We're going through it really fast. In the postnatal ward, when you go for an on-site visit to the postnatal ward of the health facility, you have noticed that the mothers are wearing jackets and well, it's evening, looks like it's cold. The babies are lying with just a cloth to cover them, no caps, no socks. And you see that there are some preterm babies that are also present in the ward. So what could the dangers be of this environment for the babies? And what are the simple doable actions that can be suggested? So for this one, I'll let you just go through the chat in the interest of time. But this is also something that is very much common, especially during the evenings in the postnatal wards. And in some hospitals where you don't have KMC implemented, you have the babies that are as covered as the mom. You see this baby had this uncovered, feet are uncovered, and the parents don't have enough education, or the staff didn't give enough information. So we have these babies that are exposed, basically. So kangaroo mother care can also be done in the postnatal ward. Cover the baby adequately, also something can be done in postnatal ward. Keep thermoneutral environment, of course, in cold areas and in places that get cool at night. We do recommend that we have heating in the room. It's not always possible. But even when it's not possible, we still have KMC, we still can cover the baby and monitor the baby's temperature and ensure that the baby is feeding. Again, a baby needs energy to thermoregulate, especially a preterm baby. And then we go through the NICU. We arrive in the NICU, and then you are doing the rounds in the SNCU, and you are in this call facility that, well, you have noticed that you already reviewed some case sheets, you already spoke to the champion, and it's seen that the babies, they are often hypothermic. especially during the night shift and especially during the evening. So what could be some reasons to this, and what are the simple doable actions in the SNCU? So we do have a hand. I can see it now. Iskandar. I don't know if you'd like to comment on this scenario, or if there's something else, we can just hold it.
Dr. Shalom has written temperature drops leading to increased risk of sepsis and increased risk of death.
Yes, definitely. There's a higher risk for babies that are cold to have infection and to die. So what will be the reasons for these babies in the SNCU? Babies that are not supposed to be cold in the SNCU, right? They're supposed to be monitored, or supposed to be good in preventing hypothermia. But this happens a lot, that we have cold babies in the SNCU every day. So what can we be doing in the SNCU? So radiant warmers, incubators, are they working or not? I have seen in some places the babies are put in the incubators because people think the incubators are better, but they are not on. They are not working. They are off. So if you put a baby, even if it's a small baby with a t-shirt that's in the incubator, that's off. The baby is in the cold environment. So this baby will tend to become hypothermic. So it's always better to provide KMC if you don't have radiant warmers, if you don't have incubators. And again, KMC is a better option, is the first option even before radiant warmer and incubators. So doors often open. There is a lot, this happens a lot in the SNCU. Of course, the door is open, but a lot of people enter and leave, especially. So a lot of circulation, there is a lot of air displacement. And well, we will have to close drafts, especially some places they do have windows and it's hot during the day and the night's coming and nobody closed the windows, so it gets cool. And a good environment for a baby is when it's hot for us. So we don't even realize, because okay, the day was so hot, we were so cool, we were so hot during the day, now it's cool and nice, but actually it's too cold for babies. The temperature of the environment is not monitored, so very important to have a room thermometer, because we know that we want that room between 25 and 28 degrees also. So if it's below that, that's a problem. So babies are not fed on time. Sometimes in these units, they're so busy and the babies are not fed on time. So the baby needs to be fed, monitor hypoglycemia, change wet diapers. And basically, babies can also, the feeding can be helped by the parents. So we can also involve parents, and that's what we want. Units are very busy. We involve parents with the feeding, involve parents with changing diapers. We involve parents in care. But if the mothers are not allowed to come into the SNCU, then we have to do something about it. We have to encourage communication and education with parents, and also advocate for policy changes. Sometimes we saw in some sites, the mothers, they have cesarean section, so they are not allowed to come. They are instantly separated from the babies. We have to encourage that. We have to encourage that the mothers, they will be in touch with their babies, or a surrogate can be the father or the grandmother. Of course, there are some also cultural reasons. So grandmothers, they are great, aunties, anyone that would be a surrogate from the mother that will be also involved in care and to also be providing heat to these babies. And of course, some units, they don't allow it. So then we have to advocate for policy changes. So temperature is supposed to be monitored as often as needed. In the SNCU, every 2 to 4 hours is ideal. So how do we manage hypothermia? So basically mild and moderate hypothermia, we'll cover the baby, remove clothes and replace with warm clothes, especially cold clothes. Put the baby in a warm room, take measures to reduce heat loss, ensure KMC, basically. That's the main thing for a baby that's starting to get cold. Oops. So apologies, I just pressed the wrong button. Bedding next to mom after fully covering the baby, and feed. Feed is very important, and especially a baby that is hypothermic. You took the measures, baby is still a little bit cold, need to check the glucose. Maybe it's hypoglycemia. Any abnormal temperature needs to be monitored. So we monitor every half hour until it's normal, 36.5, and then hourly for the next 4 hours, and then 2 hourly for the next 12 hours. Moderate and severe hypothermia, especially moderate that didn't respond to the initial, or moderate that is really low, and severe hypothermia. We had to rewarm the baby in another method, in an active rewarming, so really give heat to the baby with a radiant warmer or a pre-warmed incubator. Removing all the clothes while rewarming on a radiant warmer. The temperature set about 36.5, 37, depending on the probe position that you choose, to bring the temperature to normal range. So we aim that the temperature of the baby will be increased 0.5 degrees every 30 minutes. We don't want it to go too fast either. And you consider respiratory support for preterm that needs CPAP. Blood sugar determination, any moderate hypothermia need to check blood sugar and give IV fluids if you need. Always consider infection. Many sites will just start antibiotics, do blood cultures, and start antibiotics, and appropriate monitoring of vital signs. And quickly on hypothermia. So, well, we have a baby that we can also have preterms that are hypothermic. Again, the more we heat a baby, the more he will heat. So he will arrive to a point that his temperature is high, and the main cause of hypothermia in neonates is environmental. But a baby will become very red, vasodilated. But if we are heating the baby too much, or if it's fever, you can also have lethargy, hypotension, tachycardia, apneas. They increase significantly in hypothermia, apneas, poor feeding, irritability, feeding tolerance, and a baby that is really hypothermic, severely hypothermic, can have seizures. The first thing on hypothermia is to assess the environment, hyperthermia, observe for clinical signs of sepsis. A baby that is just mildly hypothermic, we'll consider removing a layer of clothes, decrease the bed temperature if the baby is in a bed. If the baby is on KMC, we just remove a layer. And we can take out the socks or the hat, and we check temperature every 30 minutes until it's normal. Severe hypothermia, sorry, when the baby is really hot, so more than 38, normally it's recommended a full septic screen. Even if it's rare that it's the temperature, especially when the baby is young. Babies that are older, especially terms, they will have fever, but preterms, especially the smallest ones, they will they are unlikely to have fever when they are septic. They will become more hypothermic. But if they do full septic screen, decrease bed temperature, remove clothing, but do not stop KMC. So sometimes we think, oh, the baby's too hot, let's take the baby out of KMC. This would be the last measure. We keep the baby on KMC, you can remove the layer, we can remove the hat, we can remove the socks to put down the temperature. Just by being in contact with air, the temperature will go down. And we check temperature every 30 minutes until 2 consecutive readings that are normal. So in hot weather, just this was a quick scenario. In hot weather, babies that go home, they need some advice. So especially they have risk of hypothermia, but they also have risk of hypothermia during the night. So I have seen in many sites, especially in the Sahel region, in desertic areas that are very, very hot during the day. And during the evening, they get very, very cold. And that's when they become hypothermic, these babies. So the parents, they do need, regardless the weather, advice on hypothermia and hyperthermia. And when to bathe the babies. So basically, sick babies admitted in the nursery are not supposed to be bathed until on full feeds, or they're close to discharge, or can always clean them, do some cares, but not really immerse them. And we don't need to immerse them. And if we immerse them, we risk hypothermia. And some babies we recommend after 24 hours. Okay, I'll pass this one. So basically, key messages: prevent hypothermia, maintain warm chain, ensure closer monitoring and stricter preventive measures for low birth weights and other at-risk neonates. Early detection and prompt simple interventions will prevent both hypo and hypothermia. And this seminar is on hypothermia and monitoring. So we just have a few slides on a monitor of neonate and danger signs. So we have some equipment for monitoring the SNCU, for temperature, we have monitors, stethoscope, weighing scale, pulse oximeters, glucometer, and transcutaneous bilirubin. Monitoring is usually a nursing job. It doesn't have to be, but it's usually the nurses who are doing the monitoring of the babies. And this is also part of the mentor's work to be coaching those nurses. Well, we will have nurse champions that will be very much responsible for implementing nursing practices. And this is going to be very important for teaching those nurses. So basically, we will have like a sequence of monitoring that we have to be doing for all neonates in the SNCU: hemodynamics, heart rate, urine output, CRT, BP, when you can do blood pressure, respiratory monitoring. So we always monitor the SATs of all babies, the babies on respiratory care, ideally continuously. And we have the target from 90 to 95% in preterms. Respiratory rate, signs of respiratory distress, we have already been through that. Core temperature, feeding. For feeding, we recommend monitoring amount, kind of feeding, tolerance of feeding, and also monitor for hypoglycemia, especially preterms, and growth, weight, length, head circumference. So we can monitor so did I lose you? I think I lost you.
Yes, we lost you for a few minutes.
For a few minutes?
Few seconds, sorry. Few seconds.
Okay.
Few seconds, Flavia.
Few seconds.
Okay,
Few seconds.
Yeah.
I'll put my camera off to keep my internet. So the units that can do continuous monitoring, of course, when possible, to all units in the NICU, we want continuous monitoring, but especially for those that are critically ill and unstable. It doesn't mean that because the baby's monitoring continues that it doesn't have to be written. So the nurses, they do need to be recording that. And we do have case sheets. You're all going to have case sheets that are standardized for monitoring. And well, intermittent monitoring, when continuous monitoring is not possible, depending on birth condition, we are recommending every 1 to 2 hours for sick babies. 2 hours should be enough if the baby is not unstable, and every 3 to 4 hours when baby is stable. Monitoring of all those parameters, apart from weight, of course. Monitoring should be recorded. The nurse in charge must record monitoring case sheets and monitoring sheets. Any changes, this we saw, this is not being recorded. Any changes in therapy must be recorded. So when values are abnormal, the attitude that was taken and the follow-up must be recorded by the nurse and the clinician. Anytime that something changes, needs to be recorded in the baby's file. And again, the weight must be monitored daily with birth weight, admission weight, and everyday new weight if the baby conditional permits. Right, and we arrived to the end of this presentation with just a brief slide on monitoring of danger signs. We all know danger signs, but this is also something that is important for the nursing team, and this is going to be very, very important for the peripheral facilities to understand danger signs, to know when to refer these babies. So this is going to be very much important for also education. Well, I think we are just, I don't know what time is it right now. Yes, we are 5 minutes past the time. We started 5 minutes later. I know we have some questions. So if you would like to go through the questions, if you could stay a few minutes more for discussion, it would be very much appreciated. For those who cannot stay, you can always follow up on the recording, and don't hesitate to put messages in the chat, and we'll be striving to answer all of them. So please go ahead if you have any questions. I'll stop the screen.
There are questions on the chat, Flavia, so should I bring in that?
Yes, please.
The first one is, I think Dr. Manan asked about rectal temperature.
What was the question?
What is the recommendation of rectal thermometer position? Yeah. That is one question. And the second question by Dr. Manan is, position of thermometer, is it vertical or horizontal with the baby?
Yes. So we are recommending digital thermometers axillary for this research project. Of course, rectal probes exist and they can be used. They are very much reliable for central temperature. Rectal probes, I mean. For rectal thermometers, well, there's been a concern on risk of lesion, with causing lesion basically or perforation with the rectal thermometer. So it's not usually recommended in preterms. So for this research project, of course, we don't have rectal probes. We will be using digital thermometers for measuring axillary temperature. Now, horizontal, yeah, I was saying that I had this discussion earlier with Marian. So I was saying there is no official recommendation. There are some local practices. In some countries, they would do horizontal, of course, can be done horizontal. The main thing here is that the probe is in touch with the skin of the baby and it's not in touch with air. So in small babies, preterm ones, it might be more useful to have the probe horizontally placed, the thermometer horizontally placed to make sure that it's not crossing the baby's armpit and going in contact with air. But it's more about ensuring that the probe is well positioned.
Thanks, Flavia. Professor Sanjoy asks, what is the weight recommendation for plastic wraps? It's basically.
Yes, that's a good question. So, yeah. Sorry, you want to say something, Marian?
Go ahead.
Yeah, so the recommendation is basically for small babies, for preterms that need transport and need stabilization. So a plastic wrap could be placed on a baby that's on KMC at basically any preterm could be using that. It's definitely not harmful, right? And we saw in that imaging the baby that was on a plastic wrap, completely wrapped on it. And definitely the babies that will benefit more for plastic wrap are the ones less than 32, or especially those less than 30 weeks, because they don't have the keratin layer of the skin that is developed. So they will lose a lot of water, they lose much more water for skin. Basically, the effect of the plastic wrap is to stop the skin to lose water, avoids the evaporation, basically. So in neonatal resuscitation, we say less than 28 weeks for extreme preterms. In reality, it can be used for a little bit bigger babies, not for resuscitation itself, but for transport. They can be used and they are also beneficial, and also on the top of the baby during KMC.
Next question. Thanks, Flavia, for that. Dr. Arif, how can we maintain thermoneutral environment in case of open warmer?
How can we maintain? Sorry?
Thermoneutral and temperature. A thermoneutral environment in an open warmer.
Yes, that's a very good question. So going back to the thermoneutral environment, we can do that in a warmer. So ideally, each baby will have a range of thermoneutrality. And this range, again, is where you are not losing energy to produce heat. The best way to identify it is to touching the baby's feet and baby's hand. If they are warm and the baby's core is warm, the hand is warm, the foot is warm, and the axillary temperature is normal, this baby is in that range. That's what you want. That's your goal. You take that skin temperature, and that's the skin temperature that you will put in your baby mold. Yes, Dr. Arif.
Yes, for this question, actually, the concept of thermoneutral zone is came from closed incubator, right? So in case closed incubator, we can it can actually manipulate the surroundings environment, air environment. Most of the time, as far I know, that thermoneutral environment is 32, 33 like this for the preterm babies. So our recommended NISO temperature is around 26 to 28, and in case of open warmer, we cannot manipulate the temperature more than 28. So how can we ensure if we use open warmer for the thermoneutral zone in case of?
So I think you're talking about two different things. The thermoneutral zone, we can reach on KMC, we can reach on an incubator, we can reach on a radiant warmer. And basically, I hope all of us are now, we are in our thermoneutral zone. So a baby that's losing a lot of heat will need an external source of heat. So if you're talking a baby in a KMC, the baby is covered, the baby is with mom. If the baby has a maxillary temperature that is normal and the baby has warm feet and hand, this baby is in their thermoneutral zone, basically. That's very simple like this. If you have a baby that is on a radiant warmer and the air, you are not regulating the air temperature, but you are giving the heat from an external source of heat. And this is balancing basically the air, and it's balancing all the other losses because you are warming actively the baby. So baby can also reach that zone, and it's going to be at a fixed range, the thermoneutral zone. And the way to identify that is to know that you have a normal axillary temperature and a normal feet temperature. For incubators, there are some people that developed some tables based on the weight of the baby and the temperature that you should use and the humidity that you should use. It's very helpful, but it's just, it's like a cheat sheet. The concept is very much easier than that. The concept is just the moment where you give enough heat that you keep the temperature stable and you don't spend more energy with that. And you can reach that with different methods.
Why 3 minutes is needed to measure newborn temperature? How can we continue 3 minutes when we use a digital thermometer as it beeps even before 3 minutes? That's Dr.
Do you want to
Reef
answer
again.
that, Marian? Would you like to answer?
Yeah, basically I mean, the digital thermometer might beep a little earlier sometimes, 1 to 2 minutes, and that should be fine, but you should wait for the final beep in terms of the digital thermometer, especially when you're checking the axillary temperature. I hope that answers your question, Dr. Reef. The next question is, there's a question on sheets. Can sheets, pads, jackets be safely used for transport of babies when there's no incubator? I think the best incubator is the mother, if the mother is possible, through KMC or through a surrogate who can provide skin to skin when transporting the baby from the labor room or the delivery ward to the SNCU. I think that's a concept that all of us need to have and to understand that we don't need the artificial things for this. It can be easily done with transport with the mother or with a surrogate. Flavia, if you have anything else, you can say.
No, I agree, absolutely.
Yeah. Then there is another question. Very low birth weight babies, how frequently to check their weights?
Very low birth weight babies, how frequently check their weight? So that's what we're saying. Anyway, for babies admitted in the NICU every day, this is important also to regulate the fluid amount that we are giving to these babies. We're not going to change much in the beginning for the drugs, but then after the first week, when the baby regaining birth weight, in some places it's a little bit different protocol, but we are also going to use the weight to adjust medications. But basically, the weight is very important, especially in the first week for understanding the losses of water. And preterms, they lose even more water. So that's why it's important to basically measure how much fluid we are going to give, if we're giving enough, if we should give a little bit more. So it's a very good parameter, the weight. Actually, the weight is the best parameter to measure dehydration. So that's why you should measure in the day, every day. Now, if you have a baby in the KMC unit that is there for 1 month and the baby's just growing. Of course, you don't need to measure every day. You can measure sometimes every 2 times a week, and then you can go through once a week for older babies. But for more acute babies, every day, definitely.
There is, I think there was one more question. 1 second. I'm just admitting people as well.
I think I have one here. In standard practice, what are the current recommendations on mercury versus digital thermometers for neonatal temperature monitoring? And how can calibration or accuracy be ensured in low resource settings? Yeah, this is a very good question. And that's why we are recommending digital thermometers. So basically, this is also something that for all our these canals SNCUs in this research, we are standardizing digital thermometers. So we will have digital thermometers in the delivery rooms and in the SNCUs. We agree that mercury thermometers are not very reliable measurement. Yeah.
There's one more question, I think, the last question, which is on, can we maintain thermoneutral environment in a non-functioning incubator?
Again, I said earlier that we can have thermoneutral environment in different situations. But if you have a baby that needs an incubator, I mean, if you have a baby that needs an incubator, you have a small baby or a sick baby, you will need to warm your incubator, right? So you can reach that on KMC if you don't have an incubator that is working. That's the best choice, definitely, the first choice. Now putting a baby that is a preterm on an incubator, it's unlikely to have this baby on thermoneutral environment. This baby will probably be cold, and especially if this baby is sick, especially if this baby is receiving IV fluids, and especially if the baby is on oxygen or CPAP that's not humidified and heated, because all of these are sources of cold, and all of these cool the baby down. So on the top of it, being an incubator that is not heated is a problem. It's unlikely. This baby is more likely to become hypothermic and more sick.
That's it, I think. Thank you, Flavia. I think.
Okay, yes, I think we have been already 50 minutes now on the top of our time. It's a large term because we also have a monitoring, but again, I'm very passionate by this. So we could talk a little bit more. But if you want to talk about it, don't hesitate to send a message. The video will still be there, and we'll have other meetings and happy to discuss in the future about this subject. Thank you very much for being here today. And we'll meet again in 2 weeks for breastfeeding.
Dr. Sayomi has her hand up. Dr. Sayomi, you want to say something?
Dr. Shah, I'm sorry, I cannot see all the hands.
Yeah, I can see. Dr. Sayomi? Is it an old hand? But I think it just came up, so. Okay,
all right.
She's not responding. Okay.
All right.
Thank you, everyone. Thank you, Flavia, for the great
everyone.
presentation. Thank you, everyone, for participating in the case scenarios, as well as for your responses to them in the chat and for asking questions verbally as well. Over. And we will see you probably at the next seminar. Thank you, everyone. Bye.
Thank you.
Thank you, Flavia. That was excellent.
Thank you, Aide.
Hello?
Yes, Dr. Sayomi. They're not going to let us go today.
Hello?
Yes, Dr. Sayomi,
Hello?
go ahead. Yeah, go ahead and speak,
Can you
please.
hear me? Okay,
Yes,
so
yes, we
I was
can.
talking about a non-functioning incubator, and we have a way of putting bulb in the incubator to warm the incubator so that we can use it when it is non-functioning or when the electricity is off. And that's why I was asking that question. Is it okay to do that? Does that, because that's what we do in the case when there is a prolonged outage of power and when the incubator is not functioning and we haven't been able to fix it, the mother is not available for KMC. Am I audible?
Yes, you're audible. Yeah, this is a workaround,
Okay.
right?
Yes,
You're saying that you use heated bottles inside the incubator, is it?
bulb, monofilament bulb, not bottles, because we
Bowls,
yes, monofilament bulb.
monofilament balls. I don't know what is that.
Yes.
Is it like a ball that heats?
Yes.
Okay, so it's like an external, like a small external heater, is it?
Yes, yes, yes.
It's like
Yeah.
a bulb,
So
Flavia.
a bulb,
Yes, a bulb. Yes.
like a lamp.
Yes.
Okay.
Yes.
Okay, but in incubators or in
Are
radiant warmers?
Come again, I didn't get
You say you use that
response.
in incubators or in radiant warmers?
In incubators,
Incubators, do you have enough space to put that and the baby?
Yes, we have enough space. We hang
Okay.
it above the baby. We hang it above the
Yeah.
baby, and we
Yeah.
monitor the temperature while the baby is on this. Once
Yeah.
we notice it's overheating, we put it off. And once there is electricity, we put it off.
Yeah. So
And
the only thing that I can say is not part of our recommendation. I would say that
I
this is
just want
probably,
to
yeah, it's a
say
practice.
that is what
Yeah.
we do as an improvisation when
Improvisation.
we don't
Yeah.
have time.
Yeah.
Yeah.
So it's not what we recommend. And this the bulbs, even for the radiant warmers, they can be dangerous because they can explode and they can hurt the baby. They can also burn.
Yes.
Now, sometimes there are practices that are life-saving, even if they're dangerous. Definitely, KMC is the best choice, and we would not recommend that. But there are some local practices that are done when they need to be done.
Yes,
So, but this
indeed,
is
a
not
local
something that we
practice.
would recommend.
But
Yeah,
we have never had
unfortunately.
issue of the bulb busting or causing danger.
You did not have.
We
Yeah.
have had dangerous issue with hot water bottle, so we don't use
Did
that
you have
anymore.
a skin injury, burns with the bulbs? No.
Yeah,
No.
never.
Okay.
We've never had any injury.
That would be
We never
interesting
had
to
any
do a
injury.
study. Thank you
Yeah,
very much.
that
Yeah,
would
thank you
be nice. Thank you.
for your observation. It's interesting to know something I didn't know. Yeah, thank you.
Hello. All
Yes,
right.
thank you. Thank you,
Sorry for
Dr. Sharmi.
prolonging the meeting.
Thank you. Thank you for
Thank you. No
staying.
problem.
Have a
Bye.
nice day. Have a nice day,
Bye.
everyone.
Thank you, everyone. Bye.
Thank you. Bye. Bye bye.